very much, Dr. Yasser. So we come to the last speak of the first session, and it's going to be given by myself. We're going to talk about back pain. I'll try to use this microscope, speaker. Can you hear me? All right. So just going to try to talk about back pain. I'm trying to make up for the time that we lost. So I'll try to finish in 10 minutes. So let me see. So most common musculoskeletal complaint, most common work-related injury, 80% of us will experience low back pain, and around $50 billion spent annually in the US for this problem only. Now, if you want to see the musculoskeletal diseases that are in most of the populations, you're going to see that 15 to 20% of the population would have a musculoskeletal problem. The most common one, of course, would be back pain, and we can see that at the bottom there. And of course, osteoarthritis is another very common one, and the other inflammatory ones and the metabolic ones are less common. Now, course of the disease, we talk about acute back pain, because I'm going to leave my colleague, Dr. Ahmed Salim, to talk about the chronic back pain at the end. So 90% of patients pain-free within 4 weeks. So if anybody has low back pain, give him a month, and he should get better. 90% of them actually do. 5% of the patients develop a chronic pain syndrome, and that's a different story, and we'll talk about that in details at the end of these sessions. Now, causes of low back pain, we can just divide them simply. Spinal and abdominal or visceral. The spinal are the mechanical, inflammatory, metabolic, and the neoplastic. And the abdominal or visceral, we're talking about them also. So if we want to go and see about all acute back pain, how many of them are mechanical, how many of them are non-mechanical, you're going to see that almost 97% of them are mechanical, simple back pain. So structural or mechanical causes, those are the common ones. We're just going to go through them very quickly. Prolapse vertebral disc, everybody knows that. Lumbar spondylosis, spondylolisthesis, and spinal stenosis. I'll show you some pictures, because if you get an MRI with these names, you'd know what they're talking about. And fractures, of course. Diffuse idiopathic skeletal hyperosteosis. It's a very long name. It's a disease that we actually don't treat much. It's just there. And there's the non-specific back pain. Most of the time, there's no obvious cause that can be interpreted by lab test or radiology to tell why this patient has back pain. So let's go to terminology quickly. So we have the spondylosis, the degenerative changes in both the intervertebral disc and the facet joints. And that's a very common one. Then the spondylitis that we treat as rheumatologists when you have an inflammation of the spine. And then we have the spondylolysis, a defect in the pars interarticularis of the vertebra. I show a picture about that. And then we have the spondylolisthesis. When we order MRI, we all see these terminologies, and we should know what do they mean. So this is the spondylosis, when there's degenerative changes of the facets and the other joints. We have the spondylitis here, showing the bridges between the vertebrae, which are caused by inflammation, and we have the bamboo spine, which is all of us studied that in medical school. And this is when dermatology have to be the treating doctor. And then we have the spondylolysis, and this is a vertebra. I'm going to show you on the CT scan where's the defect, and this is usually congenital. Okay? Doesn't necessarily cause pain, by the way. All right, and then we have the spondylolisthesis, where there is two vertebrae sliding on each other. Can be the cause of pain, but not necessarily. A lot of patients, we find this accidentally because we're investigating something else. All right? So spinal stenosis, this graph on the left side is a very conclusive one, actually. And where you see the spinal canal over here, where the spinal cord actually go, or is, all right? So any structure that gets enlarged and go inside this canal will cause spinal stenosis. Disc prolapse, bony overgrowth, ligamental flavum enlargement, anything that affects this canal will squeeze in the nerve and will cause symptoms. Now, this is the diffuse idiopathic skeletal hyperosteosis, which is called DISH. The X-ray does not look really nice, but most of the time the patient does not really have severe symptoms. It's just stiffness in an old person who has diabetes usually. And we see these things, which look scary, but at the end it's really not much. Now, major clinical syndromes: acute low back pain, chronic low back pain, and nerve root compression syndromes, disc herniation, spinal stenosis, and spondylolisthesis. So we're going to talk about the acute pain mostly this time. So may follow an injury of trivial strain, generally is of short duration. Recurrence are common. Patients present with severe pain, severe decreased range of movement, paravertebral spasm, and it's okay to defer full physical examination than X-ray. And this is probably the most common that our colleagues in the family care and the polyclinics see, that patients come with severe acute low back pain. And it is kind of disabling because, you know, patients usually can't walk, they want to get better very quickly. So good news is all treatment usually works. Paracetamol, you want to give him non-steroidal, you want to give him some ointment, you want to bed rest him, everything works. You don't need to refer at this point, just need to make sure that the pain does not last for a long time. Chronic back pain, precise cause is not known yet in 80%. Clinical variable spectrum, nagging mechanical low back pain, patients have it most of their day, they're really bothered by it. Periods of acute exacerbation on top of chronic pain, variable muscle spasm with decreased range of movement, and unfortunately it is refractory to treatment, and it really needs a very good expert to treat that. Complete relief, refractory to treatment, complete relief, very uncommon, and very poor results from surgery. Now, this is the nerve compression syndrome. Most common one is the, more than 95% of them actually is L5-S1 or L4-L5. And we have to really be careful about the Coda-Quina syndrome, where the patient has to go and have an immediate MRI and probably surgical intervention. And the onset may follow back injury and could be trivial. Some people sneeze and their disc prolapse for some reason. All right, so paravertebral muscle spasm happen when we examine the patient, loss of lumbar lordosis, limited spinal movement. They have a positive straight leg raise. I'll show you a picture of how to do that, very simple. And preference to flexed position. Patients usually try to flex their back. Neurological signs are variable and might identify the specific root involvement. If you did a full neurological examination, you can see muscle affection in a way and loss of sensation in a dermatomal fashion. Okay, so this is the easy straight leg raise where the patient lies supine. The physician hold his leg and try to increase it. Once he starts to have pain at the back with a 30 degrees or more, that can be a positive test. Okay, so spinal stenosis can cause pseudoclaudication, usually unsteady gait, lumbar pain usually mild, range of movement may be normal, and straight leg raise may be negative. High index of suspicion, if you really think that is the situation, it's better to do an MRI because X-ray doesn't tell you anything. Okay, so what is the role of the GP or the family doctor in treating back pain? Because as we know, it's kind of one of the most common causes why you go see a doctor. So management of most of the patients with presenting with low back pain is usually done by the family doctor. Identify the few patients with systemic illness or neurological involvement, which is a small percentage, but very important to exclude them. And those, of course, are going to need an urgent intervention. Clinical assessment, history, physical examination, and diagnostic test. A lot of patients get a lot of tests which are really not necessary, and sometimes nobody knows how to interpret them, but we'll show what you should do in a minute. Now, what are the red flags? This is very important. When do you really think that this patient should go to a hospital or to see a specialist and should not really, you might sometimes just send him right away or maybe even use an ambulance. So patients who have constitutional symptoms, they may have a malignancy or an infection in their spine. Nocturnal pain is also a bad sign. Patients have pain at night that wakes them up and they can't sleep. Neurological symptoms, severe ones. Patients have severe loss of sensation or severe muscle weakness. Saddle paresthesia, not anesthesia, where the patient has loss of sensation around their perineal area. This is really important. Patient should go to the emergency right away because that may tell us that this patient has coda equina. And of course, bowel incontinence and urinary retention. And so many patients actually were diagnosed to have a coda equina, not because of the back pain, because they could not pee. They went to the hospital, their bladder is distended, they could not pass urine, they put the Foley's catheter, took the Foley's catheter out, again urinary retention, then they figure out that they have a coda equina. And of course, if the patient have back pain, which is coming from the abdomen, that could tell us that this could be the pancreas, could be the aorta, could be the gallbladder or so. And patients who have prolonged early morning stiffness, in this situation, you would think that this patient may have inflammatory back pain like ankylosing spondylitis. All right, I'm almost done. So, diagnostic test rarely required unless symptoms persist more than 4 weeks. So, take it easy. If patients come with a low back pain, try to treat him. Make sure first on physical examination he does not have anything serious. All right? And then you can give him treatment and ask him to come back again. If his pain is persisting or getting worse, you should come back right away. 90% will have recorded therapy avoiding unnecessary tests. So really, you don't have to spend a lot of money on that. Early diagnostic testing indicated when there's significant progressive neurological involvement and when red flag, as I showed you, suggest underlying systemic disease. So, lab tests, primary to distinguish mechanical from systemic causes. So just simply CBC, ESR, lumbar spine X-ray, and usually those is unlikely to have low back pain secondary to a systemic illness. So if all these tests are normal, the CBC, ESR, and the X-ray, probably it's something simple. All right, now this is very interesting, really, really interesting. MRI testing of asymptomatic population reveals 50% have disc bulge, 25 have disc protrusion. This is a very important take-home message. A lot of patients come and see me, told me, I have a disc, this is my MRI. It's not a disc. If I do MRI of all of you, half of you will have something, and you don't have symptoms. Okay, now, the vast majority of patients with any of the 3 clinical syndromes will require no more than bed, brief rest, analgesia, and educational back exercise. And nowadays, you can just go on YouTube and just write anything you want, and it's going to show you how to do it. Specific therapy available only for major neurological compression or systemic disease. So most of the patients with back pain, it's really simple. So management of the management of the low back pain, goal relief of symptoms and restoration of function very quickly. Bed rest is discouraged, just for the first day or 2. Muscle relaxants for patients who need acute intervention. Heat, cold may help both of them actually. Some people ask me which one is better. Both of them work. Epidural steroids might be needed at some point. So, take-home message. Low back pain is the most common musculoskeletal complaint, and 80% of the US will experience low back pain in their life. 90% of patients pain-free within 4 weeks, and all treatment work. Diagnostic tests are rarely required unless symptoms persist for more than 4 weeks, and referral to the rheumatologist should be limited to the patients who may have an inflammatory back pain or a pain that you really can't explain. And I think that is my last slide.